So compassionate communities is an idea, a practice, an aspiration. It's inclusive, it's committed to systemic change, and this is the focus for the work that we have been doing in the Southwest. And as you have heard, it's a key element of a public health palliative care approach. So, okay, I won't dwell on this again. The key issue here is that the community is an equal partner in everything we do to provide really good quality healthcare at end of life. So it requires a shift in the culture of care and support, care that's more sustainable and affordable, and it's high levels of community control and ownership, in a nutshell. So the famous 95% rule, this is like in a picture for you. So 5% of somebody's day is spent with formal care, and the 95% it's spent with spouse, caregiver, family, friends. That's why there is a lot of resources in the community, and all these people can be part of providing good quality at the end of life. Now in Australia, the number of Australians dying will double in the next 25 years. And according to the latest Productivity Commission report, many Australians are dying in a way and in a place that does not reflect their values or their choices. And their end-of-life journey is punctuated with avoidable or unwanted admissions to hospital, with the confusion, loss of dignity, and loss of control that comes with it. And it doesn't need to be like this. If we think that way, and this is the way it is, death is a social event with a medical component. It's not a medical event with a social component. That's again, Professor Alan Kelleher. And of course, Libby will talk about, the medicalization of death, in the Lancet report, which she was the first author. So again, how are we doing in Australia, just to set the scene? Dying is increasingly becoming institutionalized, with 25% increase in hospital palliative care admission. Just in the last few days, the Australian Institute of Health and Welfare spending on key health services is 14 times higher for Australian in the last year of life than for other Australians. So 24,000 versus 1,700 per person. Hospital is 3 times more costly than community palliative care. Now, 70 to 80% of us want to die at home, but only 14 to 20% are able to do that. 75% of Australians haven't had end-of-life discussions. Less than 10% of us die with an advanced care directive. And really, WA Health and Palliative Care WA are doing a great job in this space. So I think that 10% is going to increase. Watch that space. Nearly 50% of over 60 years old are at risk of social isolation. 1/3 will experience some degree of loneliness later in life. So social connectedness impact cannot be overlooked. It is a health determinant. People who are more socially connected are happier, physically healthier, and live longer. Those who are socially isolated are less happy, their health declines early in midlife, their brain functions decline sooner, and they live shorter lives than the ones who are not socially isolated. So, and again, Dr. Julian Abel will show this in greater length. This is a longitudinal study, and it shows how the impact of social relationship on reduction of mortality, and it's even better than any of the lifestyle choices that we make, whether it's exercise, whether it's diet, and so on. So I'll let him speak more about it. Now, in Australia, when we did the national survey for bereavement support, we have about 1,000 people from all over Australia take part. When we asked them, who's helping you? If you can see, like at the start, like family, friends, and funeral providers came right at the top. About 80 to 90% relied on those in their community. Now, right down at the bottom, the professionals, they've been used very little because the community is doing a lot of the work, which is great. So this is what we should expect. And this is the first empirical evidence that we have for compassionate communities at the bereavement stage. And it really explains the public health model of bereavement support that we developed back in 2015, where mostly people are in low risk of developing complicated grief, and they can be supported by their family and friends. Only 30%, well, it's not only, but it is quite a bit, they need additional support. But again, this is how do you build the capacity of the community to help them in terms of volunteer-led groups and peer support. And 10% would need to go probably to mental health professionals. And that's really changed the way things are done all over the world at the moment, because before that, because everything was so, again, medicalized and pathologized, if you had a bereavement, everybody tells you, oh, you need to go and see a counselor. That's not the case, right? Now, this evidence has proved, you know, and I think people now are much better at resource allocation in terms of who needs bereavement support and who doesn't from the professionals. Now, when we ask them, was it helpful or unhelpful having, you know, these sources of support helping you? Now, again, as you can see, the ones who were most helpful, the blue, and least helpful were family, friends, and funeral providers. So again, the community is thinking they're really getting good support from their community. Now you look at the professionals, the red is much more. Psychiatrists didn't fare very well, I'm afraid. You know, but we're not generalizing, right? But this is what the community have said. So again, this really gives us, you know, this wonderful evidence that we are doing a good job as compassion communities. So the benefits of a compassion community, again, people and their carers are supported better. Equity of services, this is so important, and I'll get onto that a bit later. Community members have a sense of purpose in supporting their community members. They really want to help, but they don't know how. We need to give them that permission to be able to help. People learn how to care for one another at the end of life and can share it with others. And this is what we say to people in need. It is okay to ask for help, because if you don't ask for help, you are de-skilling your community. They're all ready to help you, and you really need to say yes, or maybe in another week or so, but don't say no, because you just shut all the social networks around you. And then you are in this isolated, you know, space where your health is going to deteriorate. Financial savings can be realized through reductions in hospital admissions and emergency presentations. And Dr. Julian Abel can talk about this. He did fantastic work with primary care, where he showed that there was a reduction in hospital admissions for the area of room where there was compassion communities work with primary care compared to the wider Shire. So having had all this evidence, we started the Southwest Compassion Communities Network in the Southwest. And our motto is every person, every family, every community knows what to do when someone is caring, dying, or grieving. We were one of the groundbreakers communities. Albany at that stage have started before us with Commonwealth funding. We started from community members coming together and wanting to do this work. These are some of the lovely compassionate community connectors. And I think 5 of them are online, which is greetings to all of you. And we, again, talking about formal and informal networks working together, we really need to do that. Now, you realize we're all spaced out. This is because COVID, we couldn't huddle together for a hug, yeah. So got different photos for the time we live in. So what do we want to get out of this? To develop, implement, and evaluate a model of community volunteers to support people living with advanced limiting illness or palliative care needs. To develop and evaluate a training program to assess the feasibility, acceptability, and preliminary effectiveness of this community model of care. Now, we've done all that. At the moment, we still have the effectiveness, which is going to be led by Professor Angus Cook from UWA. Thank you, Angus, for doing this work. But it's now, I got to say, thank you to our colleagues in Belgium, Steven van der Stikelen and Luc Delian, who wrote this chapter in now the famous Public Health Palliative Care book there, just published, the co-editors Julian Abel and Alan Kelleher. And there are complexities and challenges in researching public health palliative care, because we are talking about implementation in real-world settings, which are complex systems in which to undertake research. And so it presents a challenge to traditional research methodology. But this is how we did it. We had a mixed method research design. The first one was about longitudinal design, following those families and connectors in their work with cross-sectional measurement, pre and post intervention, and a qualitative design using semi-structured interviews with families, connectors, and referring health professionals, with the aim of giving as much information if other communities want to start something similar. We did publish the protocol for the work. And so these are the three target groups. We have the patients and their family carers, we've got the connectors, and we've got the caring helpers. The connectors are the ones who seek the caring helpers from the community. So the role of the connector is to enhance those networks within those circles of care, which again, Dr. Abel will talk about. This is taken from his article. Connectors provide assistance to the person affected with advanced illness and their family by identifying additional social and practical support they may require from within their local community, and also tap into formal and informal networks. So this is the first thing they ask a family: who is your network? And let's see how they will respond to asking them for help. The role of the caring helpers, their members could be members of the family, friends, neighbors, or other people in the community who are willing and able to assist with activities such as walking the dog, doing the shopping, collecting prescription, going to the library, mowing the lawn, making a snack, tidying up, sitting with a person who needs a break. Now, this seems such small tasks, but you will see how much effect it had on families. It's almost, as the connector said, it's little effort they put in for a big reward. And this is what people want. So these are the domains within which the connectors and the caring helpers work: personal care, medical, home, transport, social, food, pet animal, and preparation for end of life. So families would tell the connectors, yes, the neighbor could help me, but I don't want to ask. Could you ask on my behalf? And this is what the connectors did. So those are the people we looked after in this particular research program. The ones that are in the red are the ones who their level of unmet need, or their dependency on the system are either medium or high, and also their networks are either low or medium. So they needed help in both ways. So we had 20 connectors doing the training since July 2020. 13 connectors could stay with us for the long term. Up to long term, I'm saying 18 months, really not that long. Median age of connectors was 62.5 years, ranging from 28 to 74. The follow-up of families, each family were, well, in the median was 18 weeks, but some were 3 weeks, some were a whole year, 52 weeks, depending on their needs. Average number of families per connector, 3, but we had some connectors who could take 9 families. So it's very much what they can do, the way they do it in the community. It's nothing really set in concrete. We really needed to make it as organic as possible. This is the results of the training program. As you can see, the blue one is the post-training, confidence that they've gained, and it's increased quite a lot and significantly from the green lines, basically in before the training program. I love this, statement from Salno and Kumar. Community volunteers are trained to diagnose suffering, not diseases. Doesn't matter what disease somebody has. It's how they feel, how they live with that suffering. So 85 families were referred from palliative care and chronic disease teams. 43 families participated. The rest were either too close to death, or they were too involved with chemo. They were traveling to Perth a lot, or they didn't want anybody come to their home, basically. So it's fine. There were a lot of reasons for that. 47% were home alone. This is what has actually stunned me. We didn't realize we're going to have so many who, it's not like they don't have families, but where are they, So the median age of patients is 74 years, from 34 to 90. 44% were male, and 47% had cancer, 33% cardiac respiratory disease, and 14% neurological. So the type and frequency of support, like from all this wheel that you have seen, look at that, nearly 80% social support. That's what they needed. They want somebody to come sit with them, have a chat, have a cup of tea. The rest, was very, of course, we provided that, but again, that's something really interesting. Connectors have helped or sourced help, for instance, professionals to home visits to do the wills, advanced health directives. My edge care applications, they looked at how to help people, increase services, liaising with the service providers, applications for disability parking, equipment access, mail delivery, or organizing meal trains, house cleaning, transport, medical appointments, to medical appointments or social occasions, joining community groups, all-time dancing, crafts, walking groups. men's shed, gardening, firewood, social visits. But the important thing is that last one. You can do this, is giving that empowerment and ownership for people to get out of their homes and be integrated back in their community. And this is what the connectors did in a really, really successful way. Now, who are the caring helpers? And this is another, I mean, it's full of surprises, this project, actually, for me, anyway, for me. Type of caring helpers who supported the patients. So, you know, I guess because we had about 50% home alone, not a lot could rely on families or neighbors, but community service groups and individual community members were the majority who came to the help of these families. And that means that when we look at those circles of care again, the naturally occurring networks who were able to help only 26%, while there were facilitated networks where the connectors looked out to who else is in the community who could help if we can't tap into the internal networks. So again, we go to these circles of care, the inner, the outer. This is where most of the people who came to help. For instance, we reached out to Rotary clubs, right? So they did, you know, volunteer to come and help somebody be a passenger in their seat to drive them around Bunbury when they just moved in and they lacked confidence and they had illnesses. So just sitting with them in the car, showing them where Coles is, where the library is, you know, just help them a lot. And somebody, this person, they didn't know each other. So just like, how do you reach out, basically? So the first primary outcome was about social connectedness, and we used the modified medical outcome study social support survey, quite a long name. And this is what we asked the families before we started the intervention and after the intervention. So in terms of practical and tangible support, do you have someone to help you if you are confined to bed? Someone to take you to the doctor if you need it? Someone to prepare your meals if you are unable to do it yourself? Someone to help you with daily chores if you're sick? Now, in terms of social and emotional, someone to have a good time with, someone to turn to for suggestions about how to deal with a personal problem, someone who understands your problem, someone to love and make you feel wanted. So as you can see, we have increased the social connectedness. It's a significant difference with the p-value for those who are interested in this. And the two subscales had increased as well. So this is our major outcome that really wanted. So once we have established this, we don't really need to say anymore, because we know, as you have seen from the start, once you have social connectedness, all the health outcomes are going to improve anyway. The second way of measuring this is assessing the practical and social needs and support networks. So again, we looked at those families, and if they had a scale of 2, if they were able to complete a task independently, the second lower one requires some help, and the last one requires another person to complete all their help. In terms of availability of social support, members of the person network provide regular help, ad hoc help, or no help at all. So again, as you can see, although the dependency stayed the same, obviously these people are very sick and they're, you know, going downhill, so they still needed the help, but the availability of networks of support had increased by 2-folds. Again, looking at the social connectedness there. Then we've asked them to rate from 1 to 4 the impact that, you know, this program had. And as you can see, the highest impact for them was in reducing social isolation. The orange one is what the client said, and the blue one is what the connectors said. They rated their work. Now, they're very modest connectors. They've always rated theirs less than the families, because I don't think they knew how much of a difference they made until they heard that from the families. So we tried to do some network mapping for just one family. As you can see here, this is one family, and that's the kind of help they had before the intervention. And then after the intervention, with the connector reaching out to community members, family, even formal services, you can see the busyness of, you know, the interactions that's happened there, and more people coming on board from the community. So 74 interviews were undertaken, which is a large number of interviews, but we really needed to do this because, again, to basically explore all aspects. We had 28 interviews with families, 27 interviews with the connectors, covering 37 of their patients, and 19 interviews with 8 health professionals. So what the patients and carers said: always keeps her promises. A lot of paid carers really don't care, just filling in the hours. She goes above and beyond and seems to care. She knew when we were a bit overwhelmed, knew when to get involved and when to step back. It's necessary for people who don't have strong existing networks, for people who are isolated. It will open up their world. I can ask her anything, no matter what I talk to her about, she always has a sensible answer. Pretty amazing. This is one of the caring helpers for this lady with COPD. And this is the gardening group that was helping people with their gardens. So for instance, this the middle person basically was talking about blackness that would flood over him and loom for days like a heavy rain cloud. And that blackness has gone because they came and helped, and the garden was his passion, and he couldn't do anything before that. So what did the healthcare team say? Really positive, especially for clients who are early in their journey and for those who are isolated and don't have good family support. They will be encouraging more people to make use of their informal networks and support. She's very socially isolated, and our professional service is not enough to meet her social needs. So I'm very happy for her that she has a consistent person to talk to. Added another string to our bow, especially in small rural areas where there is a lack of formal services, easy to implement. The connectors, great to be given someone specifically to help fill their needs and tick their boxes. So rewarding to watch their quality of life improve. Being able to connect to those in need has brought very obvious benefit to the volunteers and the receivers. The more you give, the better the reward. The reward is greater than the effort. Fabulous program. So I get asked all the time, so what's the difference between this model of volunteering and the traditional model of volunteering? So we managed to basically get an article done. Is somebody not on mute from those online? Anyway. And the difference that we have found, and this is speaking to the connectors, they can exercise more autonomy and have more agency in providing care. This model is about a sustainable social capital emerging from genuine social encounters. And this is fresh ways of engaging with the community, because quite a few of them had worked in volunteering before. So one of them said, it's not a walk in the park, though, like other voluntary positions I've had, a whole different level of commitment, but I would do it again, highly recommend it. It's a lovely way to do volunteer work. If you really enjoy being with people and talking to people, you end up, I don't know, being part of their lives. It's really fulfilling in that respect. So it's not a job, you come back, you report to a health service, I've seen this person, can I do this for them, can I? The way you do it in the community, it happens. They're not reporting to anybody. So, well, we became finalists at the Palliative Care in WA Awards for our compassion community approach to palliative care, which was nice. And I don't know why it's not moving. Do you do something there so that it moves? Click, it's better. Okay, right. So translation in progress. Basically, where do we go from here now? So the first thing that's happened is that WACHS have taken on the program as business as usual. So it's a program, it's continuing. And what they said to me lately, it does align so well with the place-based approach to care that they are doing. This is a new kind of lingo for me, so it's great. I keep learning all the time. Great, so that's good. Local government engagement. We're starting with a Compassionate Boundaries Charter, whereby the whole community need to know how to support each other, basically. And of course, Albany and Dr. Kirsten Orett will be talking about how things have happened in Albany, and we are learning from that. Engagement with primary care. GPs in Busselton very interested to be part of this, and we engage with them in a compassionate connector program. So that's basically being discussed. And we had aspirants joined the last training program that we did. So they've started a community, compassion community, they're connectors. And I believe Albany are also starting a connectors program. So we're open to actually take this out, the educational program, the concept, everything to everyone who needs to. And I know Palliative Care WA are very interested in that. So we had a lot of pressure points in palliative care still when we did the statewide review from consumer perspectives. And I'm just trying to tell you how the compassion community approach fits with all that. Family care support. People said they haven't had enough family care support from palliative care services. Grief and bereavement support, well, you know, this we know we've always been lacking in this, and that's something we really need to do more work in. I don't know why it's going all over the place, but anyway, I had them all sequenced. Health and death literacy of consumers, again, as we talked about, death literacy, it's something that we are doing through compassionate communities. Workforce education and training, again, I think, you know, WA Health have got a fantastic program and they're doing all that, you know, based from the results on that, of this review. And then if we don't have integrated models of care that integrates all that, it's probably, you know, not going to work very well. Non-cancer conditions, they're really missing a lot on this. And this is where basically the last article written, we call them winners and losers in palliative care delivery. Certainly non-cancer conditions are in the losers category, and we need to do something about it. And this is a beautiful thing about compassion communities approach. It fits in nicely as an enabler. So again, we have all the circles of care where all the community things are happening. We've got those services here that need to be integrated, and, you know, to some levels, they're not all integrated. And these are the enablers. Compassion communities have been working with the families on integrating those services for them. And again, you know, with the not-for-profit organizations, so they are everywhere. Right, so to finish it all off, I have a video at the end to show you how it's working with families, but I thought I'll go through all that before, because once I go to the video, I can't come back unless I have help. So, so give a family a fish, it's a charitable act. Teach a family to fish, it's called sustainability. Organize a community-based intergenerational fishing collective, that is social change. And this is what we're doing in compassionate communities, the last one. So thank you for all the organizations that have taken part in this particular research program. WA Health Translation Network has provided the funding for the research program. The staff from WACHS, thank you very much for all your referrals. I mean, they're still doing it, obviously. GP Down South also took part on this. WA Primary Health Alliance were, you know, big partners. Project coordinators and assistants, PRE skiers, Kerry Gunton and, you know, Robin Richmond here. Connectors, you've done a marvelous job. Without you, this program wouldn't have been successful. We just learned from you so much. And of course, the families who have agreed to give it a go, but I think they did once they've met the connectors. They thought such great people to basically connect with and, you know, have them as friends of the family. So just a short video to show you exactly how it's worked on the ground with the connectors. Yeah.
In 80 at the Blacktown Workers Club, mid-year, and 5 days later we moved in together. So we've been together nearly 41 years. We married in 88, and by that time we had 6 children. So we're a blended family. Gus had 2 children, I had 2 children, we had 2 children. Gus was very, very fit. He was, he'd gone back to uni as a mature age, around about 60 years old, I think he went back. He loved books, writers, authors, always had. He always thought he had a book in him, they say everyone has, and he did have. And then he became ill, and we never thought it would last.
For the first few days, the doctors were saying he's got a very big growth on his lung, and he would not be surviving probably days. You know, it wasn't going to be long. And so, because he didn't want to die, he wasn't ready, we asked really that we go somewhere that we can, help to. The doctors were worried that we were trying to prolong Malk's life because we didn't want him to leave, but that wasn't the case at all. We didn't want him to leave until he was ready to leave, until he was ready to die. So, in there I looked at the compassionate program and asked to join and be part of it.
To have Gus suddenly, very, very suddenly unwell, it just threw us in a tailspin. I think everyone knows they could get sick at some point, but you never think it's going to be you. And we never thought it'd be permanent.
We still have kids sitting in desks. I came into contact with this program. There was something left after a meeting in hospital, and I looked at it and wondered about it, and had put our names down, talked about it with Malk.
I had the privilege of coming in and meeting with Mary and Malcolm. I could see they both had needs. Both were so loving towards each other and were so worried about the other person they weren't discussing their individual needs. My role was to come in and I guess get that conversation going. Both incredibly capable people, and I saw myself as being an advocate, just to slow them down and say, what do you need? Yes, you're capable of doing that, you can do that, you're intelligent people and you're in control of this situation.
It was wonderful meeting Jenny, and we got on straight away. And she's the type of person that you can talk safely with, if that makes sense. That you can sit down and you can have a conversation and talk about things that you can't talk about to other people, about how this has impacted on your life, and be honest. You don't always get the opportunity with family or friends to be honest.
I do a lot of listening with Jenny, and with Gus I was able to get a retired principal to go in and spend time with him. Gus is a very academic man and he likes an intellectual conversation, so it's sort of finding people that kind of meet that need. Yeah.
On end-of-life care, upskilling the community is a really key point that we are working towards in the Compassionate Communities Network. There's nothing worse when, somebody dies and then the family is lost. What do they want? We've never had that conversation. And I think this is where the community needs to focus on, and I think we will get a much better advanced care planning than, say, a clinician doing this in a hospital or a clinic, because we're talking about a life.
No one wants to feel helpless, and it took me a little while to realise that this wasn't so much about helping, it was about supporting and being beside people during times when they otherwise couldn't cope on their own, and that was me. I was just overwhelmed.
I would have completely, I believe, fallen over if I hadn't had the compassionate program and being involved with Jenny in the compassionate program.
Nobody wants to die, but if people are allowed to speak about their fears around death, I think it makes that process more bearable for them and those that love them.